Good evening. Thank you for joining us on this episode of Your Health. Welcome to the program. I'm Purity Musel. Now, every year, an estimated 15 million babies are born preterm, that is before 37 completed weeks of gestation. And preterm birth complications are the leading cause of death among children under the age of 5. Responsible for approximately 1 million deaths in 2015. On November 17 is World Prematurity Day, marked to help every mom, baby and family get the best possible start. This evening we are joined by Dr.Maureen Awiti, a gynecologist, and we just want to have a look at what are some of the possible causes for preterm birth, prematurity, and how can this problem be addressed. Thank you so much for joining us. It's good to have you and to see you once again.
Thank you very much, Purity. It's always a pleasure being with you.
We're talking about preterm birth, prematurity. As we celebrate Prematurity Day, what is the burden of preterm birth in the country? Because I know you're an expert and you witness these cases on your daily basis.
In terms of for the country, I wouldn't have the numbers offhand, but it's quite a high number. Yeah,
the WHO statistics are showing that the numbers are increasing. What could be the reason behind increasing cases of preterm birth?
So let's start with traditionally what are the causes of preterm birth. First of all, let us define what is preterm birth, even before we go into what is what are the causes. So preterm birth we define as any birth before 37 weeks of gestation. So any birth up to 36 weeks and 6 days, we're going to call that a preterm birth, meaning we have to have relatively accurate ways of measuring what is the gestation of the pregnancy. So even in that, we subdivide. Not all preterm births are the same. You cannot compare a preterm birth at, say, 27 weeks with a preterm birth at, say, 35 weeks or even 36 weeks. Those are two very, very different type of people or infants. So we, again, subcategorize preterm birth into what we call extremely preterm. So that is any birth before 28 weeks of gestation. And then we have in between very preterm. That will be between 28 weeks of gestation up to about 32 weeks of gestation. And then we have moderate or late preterm. That will be from 32 to 36 weeks of gestation. So, and the reason for this is the outcomes are very different. Worldwide, you find even classifying and how you manage is very different, because you find, like what I'd say called the high-income countries, they are reported to even salvage pregnancies even below 20 weeks. But again lies a challenge, because in this part of the world you find a lot of women don't attend antenatal clinic in fact what we're supposed to attend even clinic preconception.
So it's important. It's difficult,
so that we're able to date the pregnancy. For dating, we always prefer as obstetricians to use the date if the mother is sure. Research has shown if the mother is very sure about her date, it strongly corroborates if she has regular cycles. There are those who will be very sure but their cycles are irregular, so may not be able to corroborate the dates. But somebody with regular cycles and the woman is sure, it has been shown even with ultrasound that it does very well. But if somebody doesn't know her dates, it's not difficult. So we need women to go for clinic very early so they're able to do dating, because management of each of those gestations is going to be very, very, very different.
Now we want to have a look at the possible causes for that. What could, make a woman deliver before the 37th week?
Okay, so there are a myriad of causes, and they range anything from a problem with the mother, a problem with the baby, and even a problem, we call it iatrogenic, whereby for, say, medical conditions, we have to deliver the baby before time. So if maternal, it can be infections. So some infections may lead the mother to go into labor prior to her time. There are those who have what we call cervical incompetence. So their cervix is not able to hold the pregnancy for the entire duration of the 40 weeks of gestation. So the mother goes into labor again earlier than the prescribed time. You have things like, especially like multiple gestation. So you find mothers who are carrying twins, and more so what we call high order pregnancies. So those are the triplets, quads, quintuplets, so on. They are going to have early deliveries. So you find it's very common in twins, but twins can reach term. But by the time we're going to triplets and the higher order pregnancies, they tend to come much, much, much earlier than prescribed. We have medical conditions. So you find women suffer from things like high blood pressure, and you find now that will be a iatrogenic cause, because if we continue the pregnancy, it can be dangerous to both the mother and the baby. So we have to deliver the woman prior to the due date of the pregnancy. And this can be even like, I look at the big elephant in the room right now, COVID. This Delta strain has come with a lot of issues, and it's come with a lot of complications. So we are finding people who you don't expect to be having high blood pressure issues because of the COVID. They're getting breathing difficulties, and by the time the woman is having breathing difficulties, we can't continue that pregnancy. It has been shown if we deliver her, probably her outcome is going to be better. So even something like COVID is now a reason for prematurity. Back to other maternal causes, bleeding. If a woman starts bleeding, whether it's because of bleeding, can be because the placenta is what we call a placenta previa. So the placenta should not be obstructing the path for the baby to come out. And you find because of that, the woman can start bleeding. If the bleeding is significant, we can lose the mother. We're going to have to deliver the baby. Again, the placenta can shear off on its own, what we call an abruptio placenta. And if in such a situation, definitely, again, for both the mother and the baby, it's a very dangerous situation. We'd have to deliver, even if we're at 28, 32 weeks, we have to deliver the mother in a timely manner. So the list is, I think, endless. We can talk. We can talk forever and come up with all sorts of reasons. Medical conditions. She has a cardiac disease, and she's very hemodynamically, as in she's not able to withstand the pregnancy, though the pregnancy is making her disease worse. Sometimes you have to make the decision, we'll be delivering this woman much safer for her than continuing with the pregnancy.
Who is at a risk of developing these complications?
The burden is in the low income countries. So you find, unfortunately, social economic status does have a bearing, and you find that for whatever reason, people with poor economic status tend to be more vulnerable to have those. You have people with certain diseases like high blood pressure, people with diabetes. Again, they would be more at risk of having a preterm birth. And
I know one of the signs of delivery is when you begin to experience labor, but for preterm birth, maybe is this one of the signs and symptoms, and what more can you talk about?
For you to be having a preterm birth, definitely you have to go into labor. However, as I've said, they're what we call the iatrogenic, that is done by us. So a woman comes, and we diagnose that she has, say, high blood pressure, what we call preeclampsia. So that's the high blood pressure of pregnancy. And she is in danger of having convulsions. So this is like something like having an epileptic fit. And that is very, very dangerous, both for her and the mother. So sometimes we have to make a decision, do we deliver her now or not? So for medical reasons, you find that the mother is not necessarily in labor, but we have to either induce the labor or do a cesarean section in order to conduct the delivery, that it's safer for us to deliver the baby than to have the mother continue with the pregnancy. So in such cases, it'll be a preterm birth, but we would have induced the labor or done a cesarean section.
Are there complications for preterm birth? Are there some of the precautions that a woman who's had early delivery should take, or they should just continue with life normally as one who's had her full-term pregnancy.
Okay, so unfortunately, if it's something for the first time, it's very difficult to come other than infections. So like you find like during the clinic, we're going to screen for things like anemia, we're going to screen for her blood sugar, we're going to screen the high blood pressure. So again, it would be like, what are things which are going to put this woman at risk of a preterm birth? So if her pressure is elevated, that's putting her at risk. If her sugars are deranged, at risk. So they have to come to clinic so that we're able to screen, and all the things that we're screening for. Does she have a urinary tract infection? Does she have any other abnormality? So if we detect any abnormality, so for example, she has deranged sugars, the ideal thing would be, can we control her blood sugars together with probably an endocrinologist? We try to manage the sugars so that she's not at risk. Is she having anemia? Can we correct the anemia? What is causing this anemia? Find out the cause of the anemia, treat that, give her either supplements to raise her blood levels, and in severe cases, even a blood transfusion, so that they're not at risk, because people with anemia are at risk of infection, and that again would lead to probability of a risk of preterm birth. You find there's a urinary tract infection or any other form of infection during the course of the clinic, treat the infection. If a woman has a previous history of a preterm birth, again, that would be a risk factor for preterm birth in the next pregnancy. So these are women who we can offer, if investigations show that she has cervical incompetence, either we can give a prophylactic McDonald stitch. So it's like we kind of like close the cervix to stop the cervix from opening up before time. And it has also been shown that we give progesterone. So progesterone is the hormone of pregnancy. And what progesterone does, it relaxes the uterus. And for some women, you find the injectable form of progesterone has been shown that it can increase the latency period. So maybe she had a pregnant delivery at 28 weeks, maybe could push it further to about 30, 32 weeks. And for the neonatologist, any day, any week we can buy for the baby is always an advantage.
Do we have cases which cannot be avoided? Because you said again, if you have a history of preterm birth, then you are at a risk of experiencing the same problem.
If you don't know about something, you're not going to be able to prevent. So you find usually the first pregnancy, we always let mothers just do their thing. It's very limited, other than the obvious things that I said we're going to screen for. What more we can do other than what we're screening for during the course of the pregnancy. So unfortunately, in such a case, it will be that history. You will now, because of that history, be more cautious and do things in the next pregnancy to try and preempt. What we are able to do in some cases is, if we find the woman is in early labor, we can try to delay the labor, and this is to now for the benefit of the baby. So what we normally do is we'll give what we call a tocolytic. A tocolytic is a substance that is going to stop the contractions, okay? We stop the contractions, and we're only going to do this for about 48 hours. That's about 2 days. And it's going to give us time to help the baby, because one of the biggest complications preterm baby have is they can have problems with breathing, what we call respiratory distress, and they can also have some problems with feeding. So we want to give steroids, and the steroids we're giving is to help enhance the maturity of the lungs, to lessen or outright do away with the complications of breathing once the baby comes. Preterm babies, especially the very preterm and the extremely preterm, their brain development and if the labor progresses, they can get some disturbances in the nervous system. So we are also giving what is called magnesium sulfate that helps to rectify some of those complications, so that you're not getting a baby who has some neurological problems later on in life. So those are some of the interventions that we do to help when we have somebody who is in established preterm labor. But in terms of preventing per se, for some people, yes, it can happen that there's nothing you can do to stop the labor and the progression into a preterm birth.
Let's now talk about the baby. Are there signs, maybe during pregnancy, after the preterm birth, of a premature baby?
Okay,
Yeah.
so definitely, when the baby is born, obviously, the most obvious thing is the size. So of course, a preterm baby is going to be much, much smaller. But what is interesting about preterm babies, and even I think you'd have noticed, if you look at, say, a newborn, the size of the head vis-a-vis the size of the body, and a child 5 years, and you, an adult, you can see that smaller babies tend to, the younger they are, the ratio of the size of the head to the size of the body is much smaller. So you find for us, our ratio, our head is much smaller compared to the rest of the body as compared. So you find the head will be disproportionately bigger than the size of the baby. Another very obvious thing is that they tend to have hair, what we call lanugo, all over the body, some fine coarse hair that's all over the body. And that will tell you that this is obviously a preterm baby. Other things, these babies tend to have breathing difficulties, and they are also not able to maintain body warmth, so they get cold very quickly. So for us in managing a preterm baby, one of the most important things is how can we safely take care of their warmth, because they don't have enough fat. They have not built up their fat stores, which would help them to stay warm once they come out of the mother's womb. So that is one of the initiatives. And we have a very low, easy way to do what we call the kangaroo mother care. So this is the skin-to-skin contact, because the mother is 36.7 degrees, perfect temperature. That's the temperature you want your incubator to be at. So we just skin to skin, the mother covers the baby, and that warmth, her warmth will keep the baby warm. So in areas where they don't have an incubator, and even where they do have an incubator, we do encourage that kangaroo care, so that the mother is actually able to go home with this baby sooner, rather than staying in the incubator the entire time we're waiting for them to reach acceptable weight and milestones to be able to go home.
Yeah, and thank you so much for talking about how to help these babies. But these interventions that you're talking about, are they able to help both the extreme case, very extreme preterm, extreme moderate, or, you know, because I'm just trying to understand whether preterm babies can be helped. At some point you mentioned that it's unavoidable to have a preterm birth, but can we help now the babies completely and arrest all the deaths that are associated with prematurity?
So you find every center has the age at which they're going to be able to salvage the babies. Most centers, especially like in this country, do have the staff and they're able to look after. But you find in the public sector, the ailment is not the skill, it's the facilities are overcrowded. So by the time you're having more than one baby in an incubator, you find that your rates of how old the babies are going home is going to go down because of the issue of infection. So it's how do we increase the capacity and how do we make use of some of these resources. So obviously, if you have an extremely preterm baby, anyone less than 28 weeks, kangaroo care may not be a sufficient enough intervention. But if you have the very preterm and the late, moderate or late preterm, these are infants who could benefit from the kangaroo care without much further external intervention. Again, you have a term baby who has other complications. So you find that the intervention may be more severe than even a more preterm baby. So each case is on a case-to-case basis. But of course, the extremely premature, those below 28 weeks of gestation, you find it's now really very high-tech centers that are able to take care of these babies.
And as we wind up, let's talk about the complications for a preterm baby.
Okay, so for them, as I've said, the most common complication is breathing. So they have challenges of breathing, they have challenges of feeding, because their reflexes for sucking and eating are not fully developed. So you find that those are your challenge. So you'll find initially, especially the extremely preterm, they're going to be on drips rather than being given food in the stomach, because they haven't yet developed the reflexes. Their immunity is low, so they are very, very vulnerable to infection. Very, very vulnerable to infection. Their gut and all the microbiomes you need inside the gut are not yet developed. So you find when you start feeding, they get what is called, it's like their gut kind of like starts decaying. So they get a problem, even they get the stomach can get swollen, they can get intestinal obstruction that would actually require surgical intervention to look after that. So those are the most common complications. I'm sure again, we've talked about long-term, they are at risk of developing cerebral palsy because the brain is not yet developed, and in the course of the labor, these are things that can get damaged. That's why we said that, especially for the extremely premature infants, we need to give the magnesium sulfate.
And as a country, I know we can bring the burden down. Maybe what are some of the interventions that you felt that mothers and these children could be helped and save their lives? You know? Okay. Yeah.
So as I've said, prevention is always better than cure. So as I've said, the mainstay would be mothers to attend antenatal care, for us healthcare workers to really just be keen on what we're doing during the antenatal visits, so that we're able not to miss some of the opportunities, that we screened for an infection, picked an infection early, treated it early, we're not getting a preterm labor because of something that is preventable, like treating an infection. So for the preventable causes, will be to screen for them, treat them, so that we're not getting. Other than that would be for just high index of suspicion, counsel the mother on the danger signs. So what is labor? How does labor present? Can she immediately go to the clinic? Can she have a birth plan? And I tell people right from the first bit, have a birth plan. Yes, because you can get a complication at any time during the pregnancy. So we're not wondering, which hospital are we going to? When are we going to? How am I going? How am I getting there? So having a birth plan so that you're able to immediately go to a healthcare facility and get the attention that you require in a timely manner. Okay,
Dr. Maureen, thank you so much for your time. We do appreciate this informative discussion that you were part of.
Thank you very much, Purity, and looking forward to seeing you again soon.
Yeah, and that's all the time we had for your health show this evening. It's always a great pleasure having your company. I'm Purity Musel. Do enjoy the rest of our programming, and God bless.